conference. This year has been quite extraordinary, and so we're going to do extraordinary dynamics for you. We have put together an amazing panel, and I think what's going to be very different is we've always talked about the latest advances in metastatic care, and now we're going to talk about relationships as we move forward. After you hear from our very talented guest speakers. So we have a very imaginative and exciting presentation for you. I'm going to let Elizabeth, who is our grant program guru, take over right now. But thank you all for being here.
Thank you all for joining. I know everyone is still getting settled, so feel free to take your time and settle down as we begin our program. So first and foremost, hello and welcome everyone. We have an amazing program planned for you this evening. Although only an hour and a half, we have packed this micro conference with information on important collaborations between MBC patients, providers, and supporters. This evening, we will focus on how all of you are not just bringing awareness, but action to legislation, advocacy, treatment, and care. Komen Philadelphia is proud to host this event as part of our commitment to supporting the MBC community in ways that reflect the new dynamics of your world, integrating the support, knowledge, and professional care you need to face daily challenges with the resources and opportunities that translate into a higher, sustained quality of life. Now, just a quick rundown of some best practice to help us all feel we are together, even in this virtual format. First, I encourage all of you to keep your video turned on. For your knowledge, please know that this will be recorded so we can share with others who were not able to join us tonight. So whatever your comfort level it is, camera on, camera off, whatever works for you.
I don't even know how to mess with fish.
Second, please do be mindful to stay muted throughout the program to ensure the highest quality audio for our presentations. Third, feel free to submit any questions in the chat to be addressed during our final Q&A segment. When submitting a question, please be sure to mention who the question is for. Finally, all questions and answers will be held at the conclusion of our program. Please feel free to hold onto your questions until the end or use the chat as a question comes to mind. Now I introduce our first panel for this evening. Joining us, we have Dr. Arnold Baskies of American Cancer Society, Chairman of Global Cancer Control Advisory Council. Dr. Kamal Abu Hussein, hematologist and medical oncologist at MD Anderson Cancer Center at Cooper. Dr. Frank J. Rauscher III, Professor of Gene Expression and Regulation Program at Worcester Institute and co-founder of Innate Biologics, and Celeste Von Briggs, LCSW and oncology social worker at Jefferson Health's Sidney Kimmel Cancer Center. Panel, good evening. Thank you for joining us for a discussion on treatment, research, and navigation in the MBC clinical landscape. Dr. Baskies, Dr. Hussein, our first questions are for you. What do you consider one of the most important advances in treatment for MBC patients occurring over the past 3 to 5 years? And what do you see currently in the pipelines that has you most excited for taking this movement further to increase outcomes and quality of life? Dr. Baskies, we'll start with you.
We can't hear him.
Dr. Baskies, I think you're muted.
Dr. Baskies, you're still on mute.
How about now? Am
I
I
good?
So sorry about that. Let me start over. There have been a number of highly significant advances in the overall treatment of breast cancer. Let me just give you a brief perspective of 50 years of taking care of patients with breast cancer of all stages. And then I'll drill down to a brief discussion of the modern treatment of metastatic breast cancer. When I first went to medical school and started my residency and then became a surgical oncologist, the way we treated metastatic breast cancer involved removing women's ovaries and adrenal glands, and maybe giving them estrogen or progesterone, or both. As crazy as that sounds, that was the standard of care in the 1970s. Needless to say, the standard of care in the 1970s was also to do a radical mastectomy for a breast cancer, no matter what the size of that breast cancer was. And now you get the perspective of having seen these changes over the last 50 years. In general, breast cancer can be broken down into three biological groups. Those that express estrogen receptors, those that express what we call HER2/neu receptors, and those that don't express either of these, nor the progesterone receptor. So our ability to classify and therefore personalize the treatment of metastatic breast cancer has made enormous differences, which we could only dream of when I began my career in surgery and in taking care of patients with breast cancer. So the changes that have occurred have been mainly because of work that's been done in the lab and the clinical trials that have been performed, first with the NSABP, which was the National Surgical Adjuvant Breast Project. And that study is the study that really pushed forward our treatment of breast cancer overall. Metastatic breast cancer is probably the best example I can think of advances that have been made in the laboratory and have been taken to the bedside. In the early 80s and in this, actually in the 70s, we began using a drug called tamoxifen, which is still there, what we call selective estrogen receptor modulators, tamoxifen and raloxifene, and they became the tried and true method for treating metastatic breast cancer and are still used to this day. Then we added a drug called fulvestrant, which is what we call a selective estrogen receptor downregulator. Now we have a whole list of drugs that are available, medicines that are available, that are what we call cyclin-dependent kinase inhibitors, which have become tremendously successful in terms of improving overall survival and in terms of limiting the morbidity of breast cancer. So just overall, from the perspective of what we've been able to achieve first surgically and then adding the pieces that we've been able to add in terms of chemotherapy, and then with the tumor receptor work that was done, we now have a host of drugs and medications that are very effective overall in taking care of patients who have metastatic disease. The things that we need to focus on are how do we use those drugs effectively and when do we use them? And that's very, very instructive in terms of the ability of medical oncologists to be able to treat patients who have metastatic disease. But also the goal is to limit the amount of symptoms that patients have. And that's something that will be discussed later on.
Thank you, Dr. Baskis. Dr. Hussain, same question. What do you consider one of the most important advances in treatment for MBC patients occurring over the past 3 to 5 years? And what are you most excited taking this even further to increase the outcomes and quality of life?
So I have to agree totally with what Dr. Baskis mentioned. I think definitely the availability of targeted therapy for the different subtypes of breast cancer, as Dr. Baskis has divided them into the 3 main subgroups based on the expression of the hormone receptors or the HER2 receptor, or the third category, the triple negative breast cancer. We have seen a lot of advances in the last few years. Certainly the CDK4/6 inhibitors have changed the way that we look at metastatic hormone receptor positive breast cancer. A lot of oncologists like to call this the honeymoon period, where patients are on those medications in combination with endocrine receptor blockers or some form of blocking the estrogen receptor. And we usually get a lot of mileage out of this combination with very minimal side effects. It is beautiful to see patients able to avoid chemotherapy for a few years down the line and have a productive quality of life, able to function with their families and at work. So they've really changed the way that we look at this subset. Same thing goes to the two other subsets of breast cancer, the HER2 positive breast cancer. We've seen a lot of advances, and actually this year has been a very, very important year for the HER2 positive metastatic disease. We recently had approval for two very important agents that target the HER2 receptor and do have benefits even in patients who metastasize to their brain. Talking about the triple negative metastatic breast cancer, this is the one subset of breast cancer that has an FDA approval now for the use of immunotherapy. A drug called Tecentriq, which has also seen or shown us an improvement in overall survival. This is a disease that was very aggressive. Well, still it is very aggressive. So to be able to show an improvement in survival is such a great achievement. Definitely all of this is important, but also the use of genomics and the use of the genomic tests in order to identify some mutations that could be targeted by new therapeutics is extremely exciting. Testing our patients for certain mutations like the BRCA mutation, the germline mutations, which also enable them to be candidates for treatment with oral therapies like PARP inhibitors. This is just an example of how the whole map for treatment of metastatic breast cancer has changed. And I think the one thing that is always exciting for all of us is the availability of different types of clinical trial that our patients can enroll in and hopefully move this forward even better, like in the next few years.
Thank you, Dr. Hussain. So the group here tonight knows a great deal about the benefits and potential of entering a clinical trial. However, clinical trials aren't a blanket answer for every MBC patient. The decision is as much a philosophical one as it is a medical one. Dr. Baskis, would you like to start the discussion on this?
Sure. Clinical trials are the lifeblood of medical improvements. Suffice to say, without clinical trials in cancer, we wouldn't have the array of drugs and targeted therapies and personalized medicine that we're experiencing today. Now, clinical trials are a very important part of how we approach life of patients. And by that, I mean that a clinical trial isn't necessary at the beginning of treatment, although it can be important if there's a new drug available or if a patient has failed standard treatment. But clinical trials should be discussed with patients at the appropriate time. And what is the appropriate time? That's a very individualized discussion. Not all patients want to go on a clinical trial. Not all patients are appropriate for a clinical trial. But clearly, when there's a new treatment available, it is very reasonable to offer a clinical trial to every patient who is eligible for it. But then it becomes a very philosophical decision on the part of the patient if they're looking at, for instance, standard treatment versus something new. But clinical trials are so important, and if we didn't have clinical trials now, we wouldn't have the types of treatments that we have in terms of CDK inhibitors, even tamoxifen, which is the lifeblood of patients who have estrogen receptor positive disease. So clinical trials are important. They are incredibly important when it comes to advancing medicine in general. But that discussion between a patient and the physician is ultimately the most important part of the steps that need to be taken before one enrolls in a clinical trial.
Thank you, Dr. Baskis. Dr. Hussain, your thoughts?
I think clinical trials are very, very important to be considered and discussed all the time. Definitely, they are not the answer for every patient, but they are great answers if it is a nice fit for the patient at their stage of discussion with their physician. So I think it's really important for any patient when they are looking into clinical trials to, first of all, understand and have a very clear understanding of the different phases of clinical trial. And to put it very simply, I think there are three different phases for clinical trials. Like to think of phase one as the initial phase where we have identified a different therapeutic agent and would like to answer one question: is it safe or not? So it's a question that is trying to determine toxicity or the safety of the dose that we're studying. So they keep testing different doses until they get to a level of an unacceptable toxicity, and they go back to the one dose before. Then they move on to phase two clinical trials. And in phase two, they're trying to answer whether it is effective in treating that condition or not. And if that is found to be effective, then they move to phase three. And phase three is a comparison between the standard of care, which is what we are allowed to offer to patients based on the FDA approval, and this new therapeutic agent. So it is important for patients to understand that clinical trials will never offer you anything less than the standard of care. So this is really important, and that is particularly the phase three, which the majority of clinical trials are. So to be able to discuss this with your medical oncologist and talk about the schedule of administration, talk about the toxicities involved, are they acceptable to you, or you like the standard of care better? Also find out geographically, is it something reasonable for you to go and travel to that center very frequently to do the physical exams and so forth? So yeah, I think it should always be brought to the table of discussion in treatment of metastatic breast cancer, for sure.
Thank you, Dr. Baskis and Dr. Hussein. Moving into research, Dr. Rauscher, what's going on in the labs right now in terms of breast cancer metastasis, and how do you see this work translating into better treatment and quality of life for MBC in the next 5 to 10 years?
Thank you very much, Elizabeth, and to all the participants and people online and my wonderful colleagues in the clinic, Dr. Hussein and Baskis. Again, I'm a lab rat. I look for new targets, which we desperately need to develop over and above hormones, hormone therapy, and cytotoxic therapy. We have to move past that. And a lot of us in the field have been looking in the mouse and other test tube-like systems where you can measure the ability of cells to move, which is what metastatic cells do, and invade a blood vessel or another tissue. By sequencing every gene that is turned on or turned off when cells move out of a primary tumor into a new environment, we can tell which genes are on and off. And that's one extremely exciting avenue. And when asked if one could have a bit of your metastasis or your primary tumor or some of your blood to do these type of studies, I'd encourage everybody to say yes and jump up and down, because it allows us to do extremely good comparisons between cells that are able to leave the primary tumor and populate the brain or the bone or the lung versus those that cannot. And that is a very good black and white, well-controlled experiment that you can do in a single patient sometimes. So it's not comparing patients, it's comparing within patients. Now, with that said, and in terms of some new targets, I think one of the most fascinating things are our concept of how breast cancer cells can leave the primary tumor, get into the circulation, and then get out into another organ. That's many steps right there. And not produce a new tumor, but become dormant is something that is really important. We're understanding much more. And this happens quite routinely, where these cells, once they get out into the brain or the bone or the lung, they do not start forming another tumor right away. Sometimes they are dormant, they're non-proliferative, and they can hang around, evade the immune system and everything else that's trying to wipe it out, and stick there for 5, 10, 15 years sometimes.
Yeah.
That is why one see clinicians, as Arnold and Dr. Hussein will attest to, you see very late recurrences. And we can tell genetically they are the exact same tumor. Nothing has changed if you compare their genetics to the primary tumor that happened 10 years ago and the one that is now showing up in your bone, in your brain. And by and large, unfortunately, these late these late progressors, let's say, are often very resistant to therapeutics. And we're getting to, what we're really understanding now is what makes these cells dormant. It's only 1 in 1,000 cells or even less, your tumor, that can perform all these metastatic steps and stay dormant. The second thing, so we're able to compare these cells and asked what particular molecules, what particular genes in these cells that makes them able to be dormant and still survive. Second, from that study, we can kind of predict what kind of drugs we could use to target the dormant cells, and that's what you'd really like to do. You have to predict, and it's a relatively easy prediction to make, that a good fraction of breast cancer cells, even in really good prognostic low-grade breast cancers, there'll probably be dormant cells out there in different organs. We have to target them very early and very rapidly. One possibility is, why don't we design drugs that recruit these cells that are dormant back into the cell cycle and get them dividing again. Dividing, we can hit them with cytotoxic drugs that we know work really well. And that is one strategy, which a bunch of us are testing. One other newish concept that is coming out in the mechanics of metastatic breast cancer is that cells do not leave the tumor by themselves. Okay, they leave in groups. They leave as a cluster of cells that have that take part of the tumor microenvironment, the matrix, with them. It's kind of a fibrous thing that holds them together. So, and this fibrous matrix, which floats around with a bunch of tumor cells in the blood, is what is causing metastasis. It's not a single cell; it's a clump. You know, and it provides, this clump provides a survival advantage for these tumor cells. It's almost like when your kids leave for college or they go away from the home, they take their furniture with them. So wherever they populate, whether it be a dorm room or anywhere else, they are comfortable with their surroundings. Tumor cells do the same thing. The only difference is the tumor cells don't borrow your money when leaving the primary care. But in any event, that provides new targets. So why not we do not target the metastatic tumor cell? Let's target the matrix itself that's keeping it together. And I think that's a very, very powerful approach. If we can break up these clumps, you know, and target the matrix holding them together, then I think that would be a much more powerful approach rather than trying to kill them. So those are two things that I see coming down the path as very, very good targets that are predicted by very, very good biology and genetics, which we will see in the relatively near future.
Thank you, Dr. Rauscher. Patient navigation, especially in oncology, is a critical resource for support and community for patients. Celeste, how have you seen the need for psychosocial support change the way you and your team approach caring for MBC patients?
Thank you. First of all, I want to thank Susan G. Komen for hosting this important event. As all of you know, navigating the healthcare system can be so challenging. And when you add the greater the complexity of the disease and treatment options, that can translate into barriers to care. In my work as an oncology social worker, I'm often tasked in assisting patients and families along the whole continuum of care to address psychosocial needs as well as other barriers that can impact their cancer care. I'm often meeting with patients, exploring available resources, and then making referrals to help them to be able to get the care that they need. Some of these barriers can include financial concerns, either with the cost of treatment or other aspects of their life, utility bills, rent, transportation back and forth to treatment, or employment-related concerns, and facilitating those referrals to supports to help people to be able to still continue to get the care that they need, not miss appointments, and stay on track with their cancer care. I also think that another unique challenge to the metastatic breast cancer community is the additional layer of psychological and emotional support for both the patient, their partners, their families, and their kind of circle of support. That could be initiating family meetings to make sure that the patient, their caregiver, and the care team are all communicating the complex medical information and making the best decisions that they can for their circumstances, and that the care team knows what the other psychosocial concerns and barriers that patient may have, and are there resources that we can help navigate and help make those barriers minimized or even go away. And I think an additional layer of complexity has been with COVID-19. The increased use of telehealth, the increased stress on family systems, on financial concerns for patients. There have been some true difficulties. I think with the telehealth, what we found at Jefferson was that the increased use of telehealth for the metastatic breast cancer community was a little positive and a little negative. Some of the positives were it reduced the need for so many back and forth appointments, things that was difficult for people to navigate. Patients and their families didn't have to travel down for multiple appointments. Many of those could be done over telehealth. And then they were minimizing some of those stresses. But, you know, everybody isn't necessarily a tech person. So we implemented at the onset of COVID a telehealth task force to help transition and address those needs for folks who may not have been so tech savvy, help them make sure that they connected to their providers, and connect to resources if they didn't even have the technology to do a telehealth appointment. So those were some of the concerns that I think are unique to the metastatic community and then amplified during COVID.
Thank you, Celeste. Okay, panelists, this is our lightning round, so to speak. We'll start with Dr. Hussain, then Dr. Rauscher, and finally Celeste. In 25 words or less, please summarize one thing you heard from your colleagues on this panel that has you most excited about the future of MBC treatment and/or care. Dr. Hussain, we'll start with you.
Well, that's not an easy question to answer, but I think there's a lot of exciting things. Definitely, clinical trials will have to be the most exciting thing, but I think it's really important to remember that the management of breast cancer in the metastatic setting is a team effort. And as much as we manage the clinical aspect of it, but the social aspect and the stress on the family and the patient is really tremendous. So the social work and the financial support that any practice can provide to patients is really, really important. And besides that, also, I don't think we spoke about palliative care. This is really important in the management of symptoms. So that is something that is integral in management of metastatic breast cancer.
Thank you, Dr. Hussain. Dr. Rauscher. Dr. Rauscher, I think you're still on mute.
25 words or less. Wow. I was reminded by Dr. Hussain the tremendous advance that happened this year, or possibly early last year, on the approval of govitecan, the HER2 directed conjugate therapy, which is one of the first really active medicines that we've had approved in quite a long time. Again, that was in development for 15 or more years. It is extremely potent and selective. It can get into the brain. It can reach a lot of these tumor cells that have already metastasized. And I think that's one of the most spectacular things that have been pushed through for myself in the last year. Forget the genes. We're going to have to treat people that have metastatic disease. And those are the agents that are going to do it. Thank you.
Thank you, Dr. Rauscher. And finally, Celeste.
I think all of this is exciting. I think one of my hopes for these types of conferences is translating all of these exciting developments to the patients, their families, and the community, so they know how to advocate for themselves in the clinical space, and to be encouraged that that there is hope, there is treatment, they can participate in clinical trials, they can educate their family members, they can just really, all of it is exciting to me. Anything that can give patients hope and make every day the best day for as many days as they are able to get.
Thank you, Celeste, and thank you to our esteemed panel for taking us through the MBC clinical landscape and the future of patient-centered care. Next, I'd like to introduce our first address this evening from Meryl Weinreb. Meryl is a retired pharmaceutical marketing executive with extensive experience in oncology, both from an industry and personal perspective. As a 3-time breast cancer survivor, she was responsible for several award-winning patient education and support programs for breast, prostate, and lung cancer therapies. Ms. Weinreb is very involved with Komen Philadelphia. She served 7 years on our executive board and continues to serve as our education and public policy chair. Passionate about public policy, Meryl leads public policy initiatives for Komen's Advocacy Alliance in Pennsylvania and Delaware, and has served on Komen's Advocacy Advisory Task Force. She is also a Komen Scholar, member of Komen's Advocates in Science Steering Committee, and engages in a number of other activities too numerous to mention. But in closing, I will mention one more important role, especially for all of you here tonight. She is a patient advocate and works closely with researchers to ensure that their work addresses the needs of breast cancer patients. Tonight, Ms. Weinreb will discuss advancing legislation and advocacy. Meryl, welcome.
Thank you, Elizabeth. Are you going to pull up my slides, or should I share screen with you? Because I need slides. I mean, it's really hard to talk without slides. So,
I will gladly pull up the slides.
all right, and then I'll just tell you when I need for you to change. How's that? Excellent. And there it is. Perfect. So we've heard a lot about efforts around education, support, both financial and emotional, and groundbreaking medical research. All of these are really important action steps that we take to fight metastatic breast cancer and improve the outcomes for patients who are struggling with stage 4 disease. And they're all absolutely critical. But there's another aspect of our fight that often isn't highlighted, and that is the importance of political action. And I know this time of year we are being deluged. I mean, unbelievably deluged with political ads and debates and polls and screaming headlines, and it's really easy to want to zone and tune out all of that noise, especially for those of us who may be dealing with a serious illness and also having to deal with all of the issues associated with the pandemic. But for those of us who are in this fight, public policy is critically important. And it's really important for those of us who are trying to remove barriers to care, finding new and more effective therapies, eliminating disparities in treatment, and reducing the financial hardships that many patients encounter when they're diagnosed with this disease. So every year, Komen organizes an advocacy summit. There's a picture of several of us at a past one. And what we do every year is we descend upon Capitol Hill, hundreds of us, on a lobby day, and basically lobby our legislators on issues that are important to breast cancer patients. And this year, unfortunately, because of the pandemic, we had to do it virtually. But nevertheless, I think it was a pretty effective day. I was privileged to join 3 other area patient advocates. I think 2 of them might actually be on this call this evening. Jamel Rivers, Roberta Albany, Tamika Bryant, as well as a gal by the name of Kim Sibelko, who is with our National Komen Scientific Team. And we spent a day, it was on September 1st, calling on 5 of our area congresspeople to talk to them about things that we felt were really important that our government can help in this fight. So what I thought I would do very briefly is kind of review some of these issues that we discussed with our legislators, why they're important, and at the end, maybe give a few suggestions on how you could join in this fight if I've piqued your interest. So next slide, please. Obviously, the first thing is around research. And a lot of the research that we heard discussed this evening, a lot of that, well, all of it takes a lot of money. And funding for medical research is absolutely critical. And a lot of that research comes from grants that are given by the National Institutes of Health and its National Cancer Institute. Many of the breakthroughs that we talk about have had in some way some connection with funding and support from those organizations. And while 44.7 billion sounds like a lot of money, and I guess it is a lot of money, it's the least that we can do to try to move forward in trying finding those breakthroughs. A smaller amount of money that we advocate for, although still very critically important, is within the Department of Defense. And frankly, 150 million in the Department of Defense budget is not even a rounding error. It is a tiny little bit of money, but absolutely critical. It is a program that's been around for about 20 years. It's the Breast Cancer Research Program, and it funds breakthrough research projects specifically on breast cancer. And many of these relate to metastatic cancer and are absolutely critical in finding the medical breakthroughs that we're going to need in the coming years. So we spent some time on research funding. Next slide, please. The other program that involved funding is a program that's also been around for several decades. It's the National Breast and Cervical Cancer Early Detection Program. And this is a program that actually goes through the CDC in the federal government. It gives money to the health departments of all 50 states to support screening and in some instances, actual therapeutic care for women who are either low income or uninsured. And many of you may have heard of these programs. In the state of Pennsylvania, it's called the Healthy Woman Program. In Delaware, its name is Screening for Life. In New Jersey, it's called the SEED program, but it's all essentially the same thing. It basically provides screening and diagnostic services to people who can't afford it. And every year they run out of money. Many, many more women are eligible for this program than can be served because of lack of funds. And this program by law is fully appropriated for $275 million in support. It doesn't always get that full amount when the budget's put together. So we spent some time stressing how important that program is and urging full funding for this program in next year's budget. Next slide, please. So then we moved on to 3 bills that we feel were really important, and I will go through them pretty briefly. The first one is called the Access to Breast Cancer Diagnosis Act, and it has a very catchy ABCD Act. These numbers that are shown here, this is how we identify these bills. There's a House bill. It is number 2428, and in the Senate, it is 3216. And basically what this bill is all about is trying to reduce out-of-pocket costs for the diagnostic follow-up on imaging. Many of you know that you've had the experience where your initial screening mammogram may be free, but if they find something and they need to do additional diagnostic follow-up imaging like an MRI or an ultrasound, that patient may be on the hook for some out-of-pocket costs, hundreds of dollars in some instances. And what can happen for women who can't afford that is they may delay getting their diagnosis. They may get a delay in being treated. And this bill is seeking to eliminate the financial barriers in terms of getting that timely diagnosis and the critical care that those patients need, regardless of their ability to pay. So that is what this legislation is about. Next slide, please. The next bill that we talk about is also important, is the Cancer Drug Parity Act. And you may have heard about this, and I'll try to give you a really brief explanation of what this is about. Most of us know that if we have insurance, it's in two parts. There's a medical side of our insurance, and there's also the drug side of our insurance. And for cancer patients, if you have to go to the clinic for classic chemotherapy that is infused into your arm, it is usually covered by your medical side of your plan, and usually fully covered by your medical plan. However, more and more of the more exciting therapies that are coming into the market and for metastatic patients are oral medications, drugs that you swallow. And these are covered by insurance on your drug plan. And many of us know that our drug plans have tiers, and the newer cancer drugs are high-tiered drugs and can cost a huge amount of money. And many of us have drug plans where we're on the hook for co-insurance, which means we have to pay maybe 20% or 30% of the cost of that drug. And that is a huge problem if your cancer drug costs $100,000 a year. Most of us do not have $20,000 sort of lying around to pay for our share of that drug. 43 states, plus the District of Columbia, which includes our area, Pennsylvania, Delaware, New Jersey, they have all passed legislation that says that insurance companies cannot discriminate based on the form that your therapy takes, that they can't charge more for an oral therapy versus an infused one. The problem, though, is that many people have insurance that is not governed by state law. It's governed by federal law. So we need federal legislation to do what our state laws already do. And again, no cancer patient should be penalized because her optimal treatment is swallowed versus infused. So that's what this bill is all about. And we've introduced it for the last couple of years. More and more, we're getting more and more support, and we're hopeful that we'll ultimately get a federal bill on this. Next slide. And this one is the last of the three bills that we talked about with our legislators. And it's the Metastatic Breast Cancer Access to Care Act. And this is critically important to our metastatic community. This bill, if passed, would waive the waiting periods for Social Security disability insurance and the waiting period for Medicare patients, Medicare benefits for patients with stage 4 disease. It is totally outrageous that newly diagnosed metastatic patients have to sit around and wait for 5 months in order to get Social Security disability insurance. If you have metastatic disease, 5 months is an eternity, and it is totally unacceptable. And additionally, having to wait 2 years for Medicare benefits is also insane for someone who has metastatic disease. This is sort of just basic understanding of how these diseases work. Metastatic patients do not have this kind of time. If they cannot afford or have or already have insurance that can cover their care. The other concern is that many patients, when they're diagnosed with metastatic disease, they may lose their employment. They may not be well enough to be able to work. And if they can't work, they would lose their insurance that they have and then be forced into a situation where they would have to wait an unbearable time to get coverage. So this is absolutely a critical piece of legislation for the metastatic community. Next slide, please. So the question is, well, what can you do? Well, one of the things I would suggest to you is to start exercising your First Amendment right. You know, when we think about First Amendment, we often think about freedom of speech and freedom of religion and freedom of the press. But one of the freedoms that is enshrined in our Constitution is the freedom to assemble and to petition your representatives in Congress. And I would urge you to learn who your representatives are and where they stand on these issues. Thank them if they are already supporting it. And if you've got a legislator who is not yet supporting this, ask them why. We've got an election coming up, so voting is critically important. And you can learn a whole lot more about what I've been talking about at the Komen's Advocacy Hub. Regrettably, this particular URL is not the most memorable one, so take a few moments if you can to write it down, and I'm sure Elizabeth will end up maybe sending it out to all of you if you ask. But you will find on this website lots of information about what I've talked about, links to where you can find out if your legislator is currently supporting this legislation, and also some webinars on how to be an advocate and how to do grassroots advocacy and how to effectively talk to a legislator. One of the things that we've learned is our voice has power and your story has power. Both Roberta and Jamel, who were with me on this lobby day, you know, I can spend hours talking about the statistics and all the data and the facts, and it's, you know, it's not all that effective. What is effective is for a legislator to hear a personal story from a constituent who is dealing with these issues and who can talk about how it has impacted them. And it's powerful, it has an effect. You have probably a lot more power than you realize in terms of affecting the way our government treats our cancer patients. Next slide, please. I love this quote. It's presumably from Thomas Jefferson, although I've done some research and it's somewhat doubtful if he actually said it, but let's just say that Thomas Jefferson actually said this. We in America do not have government by the majority. Instead, we have government by the majority who participate. Next slide, please. So consider, if I've made you interested, to become an advocacy insider. You can send an email to policy@komen.org. You can go to that site. If you sign up with policy.org, they will occasionally send you updates about what's going on in the legislation and where we are. And it's just another way that we can fight metastatic disease. So thank you.
Thank you, Meryl, for this incredibly important reminder that policy is primary for the delivery of equitable and effective healthcare, and that our collective voices are the most important tools that we can use in legislation.
Thanks, Meryl. That was great.
Next, I introduce Dr. Barbara Segarra-Vasquez, presenting our second keynote address of this evening. Dr. Segarra-Vasquez has been a faculty member at the University of Puerto Rico for 30 years and is the Dean of the School of Health Professions and one of the principal investigators of the Hispanic Clinical and Translational Research Education and Career Development Program. She was diagnosed with breast cancer, stage 2B, in December 2003, and was in remission for 13 years before a recurrence of metastatic breast cancer to the skin in January 2017. A volunteer for Komen, Puerto Rico since 2006, she was board president for 4 years and currently serves as member of the Puerto Rico Cancer Control Coalition and is the leader of the Survivorship Committee. She is the Vice Chair of Steering Committee for COVID Advocates in Science and is a member of SWOG Patient Advocates Committee. She is the founder and co-investigator of Hispanics Increasing Diversity to Enhance Advocacy in Science. Dr. Segarra Vasquez will take us through advocacy disparity and why it is critical to be a voice at the table. Barbara, thank you for joining us. Let's begin this discussion on combating disparities and elevating patient advocacy.
Thank you, Elizabeth. I'll wait for my slides, please. And thank you for inviting me, and it's an honor to be here sharing with all of you. And after Meryl, my colleague and friend. So what we're going to be talking about is combating disparities and elevating patient advocacy. Next, please. So what I want to do is do a little review on the evolution of advocacy in breast cancer, describe advocacy engagement outcomes, my experience as an Hispanic advocate, describe relevant aspects of cancer disparities and minorities, and describe participation of minorities in research. Next one, please. So sometimes we take advocacy for granted, but it has been a fight for many, many years for advocates to sit at the table. It was in the early 90s when breast cancer advocates demanded attention, and they were able to win seats in institutions like National Cancer Institute and American Cancer Society. In 95, also DOD, the Cancer Research Program, began to include advocates as voting members, and those of us who had participated, we have the same weight as researchers, so we sit at the table and defend it. The FDA also included advocates in 1995 and made them voting members in 1998, and in 2000, Komen increased Cancer Research Foundation advocates in the review panel. So it has been, now we have patients in different seats, but this is how it began. Next one, please. So it's important to have advocates, and again, we take it for granted, but what we have found is engaging advocates in research improves clinical research feasibility, because advocates can really guide researchers on how it could be done to have success. We can improve accrual and retention of patients in clinical trials, again, because we have gone through it, and we can explain and reach out to other peers as well. It increases public trust through enhanced transparency and accountability. Who else to defend and talk about the research and the patients and the advocates? We can assist in disseminating research findings, and it helps other advocates understand and effectively communicate about science. Next one, please. So my evolution as an advocate, as Elizabeth mentioned, I was diagnosed in 2003. So after I finished all my treatment, chemo, radiation, etc., in 2004, I knew I needed to do more and pay forward in service what I had gained in health. So I started working with other patients. Then I began very active in Komen, Puerto Rico, and which I volunteered for more than 10 years. And I was also part of the board of directors, but I started as a research advocate in an opportunity that I received a scholarship to participate as a AACR scientific survivorship program in 2012. And that was really an eye-opener. And even though, as you heard, I'm a dean back home, back in Puerto Rico, and I'm a medical technologist by trade, I never realized how I could put in science direct as a patient. So in that conference, I learned about other opportunities, about being a reviewer for DOD. So I applied, and I have done that 4 times. And actually, very little Hispanics do participate in this. And I also learned about the Alamo Breast Cancer Foundation Patient Advocate Program in San Antonio. And since then, I attend almost every year. So it was in the AACR that really opened my eyes. Next one, please. So being, these are kind of pictures or logos of where I'm very active at, and started in the left and in Komen, Puerto Rico, but have been really active as an advocate in the United States in different committees. And people get to learn about what you do. And wherever I go, especially in the bottom, you can see we did a blog about why it is important to include the Hispanic voice in everything we do. And to the right, as it was mentioned, I'm a patient advocate for SWOG Cancer Network, and I think I was the first Latino to be part of this group of 30 advocates that have been participating for many, many years. Next one, please. So my experience as a scientific advocate has been very enlightening, and I've been able to share patients' perspective, especially from a Latino view. I'm happy I've been able to contribute in the design of a research, and it's very rewarding when researchers really listen to you and make the changes in their design when you give them an opinion. So we all can do that. The impact of I have seen the impact of advocates in the final scoring in DOD, for example. I've been able to learn more about science and promising research with things like we're doing here today. And I've been able to help give a face to scientists about patients. And most of all, what I find, what I try to do all the time is represent the Hispanic Latino voice. Next one, please. So when I started since 2012 participating in all these meetings, I kind of noticed that the amount of Hispanics or Latinas in this group, very powerful group of advocates, is very limited. And I can, from all these years, maybe 7, 8 people that we go regularly and include our voice. So I wanted to do something about it. So I got together with 2 other colleagues in Puerto Rico, Michelle Martinez and Dr. Ana Pacheco, and we decided to design a program called H-Ideas, and it was Hispanics Increasing Diversity to Enhance Advocacy in Science. And what we wanted to do is create a scientific advocacy group that will be trained in research, health policy. Some of us know that there's Project LEAD in the States, but there's a lack of participation of Hispanic and even Puerto Ricans. There's a lot of Puerto Ricans who are bilingual, and I think they could have benefit from these opportunities and if they knew. So we wanted to address that lack of participation and increase minority population trained to serve and review panel. Next one, please. So we found a funding like $10,000 from a local organizations, and we recruited 15 breast cancer survivors. We did an intense training over a weekend in a hotel, and we went from general talking about cancer, breast cancer, IRB, research, clinical research, etc., and advocacy. And then we trained them every other month. It was in the middle of, we began it just before Maria hit Puerto Rico, so we had to take a break of 4 or 5 months because most of us were without power for 3 months or more. And these ladies were calling me, I want to meet, and I said, let's wait for everybody to be settled. So we got back, and I'm happy to inform that almost 35% of the people who participated had applied to scholarships in the States and had attended San Antonio and Lynn Sage, etc. One of them had been invited to a pharmaceutical patient panel, and she was the only Hispanic there participating. They have done research review. So it's a program that I would like to emulate and have more Hispanics in the United Mainland to participate to have a bigger voice. Next one, please. So when we talk about minorities participation in research and we see the literature, there has been a great initiatives to do. Like in 1993, the Rehabilitation Act was for increased minorities and women in research. And from there on, there's different logos, Healthy People 2010, 2020, etc. Next one, please. Sadly, 20 years after it, the research participation does not reflect the country's changing population. Minorities represent 30% of the US population, and in 5 states, for the majority, so it's important. And NCI trials in which primary focus is racial and minority population is less than 2%. Next one, please. And this is just a sketch of Latinos, and this was from 2018, I'm sorry, and 17% of the population were Hispanics, and it's the fastest growing minority population in the United States, and it's felt that by 2025 is going to be the highest minority accounted for 20. And you can see that the burden of cancer is 1 in 3 will be diagnosed, 1 in 5 will likely die, men, and 1 in 6 women will likely die from it as well. Next one, please. So, and looking about what has been done after all these acts have been, there was a systematic review of cancer treatment and prevention study from 2001 2010, and only half of these studies reported a race and ethnicity. And from those half, 51%, only 2% were Hispanics. And you can see African American 6%, etc. But Hispanic, it represents 17% of the population, and only 2% had participated in this analysis. Next one, please. There's also last year, JAMA published article said disparity of race reporting and representation in clinical trials leading to cancer drug approval from 2008 to 2018. And there was a quote there saying that Black and Hispanic patients in particular were underrepresented in trials that led to cancer drug approvals. There were fewer Black and Hispanic patients in cancer clinical trials that would have been expected. And the big problem here is that these drugs, when they are approved, are used by all of us, you know, Hispanic, African American, everyone. So I think we should be participating because we are seeing every year differences in ethnicity and race. So next one, please. And when we talk about genetics, genetics is something that is moving on forward, and we talk about personalized medicine and precision medicine. Sadly, in an analysis done in 2009, only 96% of these studies were done in European descended population, and less than 10% of African American and Hispanic had participated. So if we don't do something about it, using this data of genetic testing will only increase health disparities. Next one, please. So Latinos have a lot of barriers affecting cancer patients. Some of it is access to care. A lot of Latino population are either underinsured or uninsured. Is the lack of knowledge and information, especially in their own language. We can all, those of us who have been diagnosed with breast cancer, I was lucky to be in Puerto Rico when I was diagnosed, and I spoke the language. I didn't have any problem asking questions, but you can imagine the burden in a patient that doesn't understand well the language and is trying to navigate to the system. And we all have seen how navigating is so difficult. Latinos have a heavy workload, sometimes 2 jobs or more. There's fear, there's religion belief, there's financial burden. So this is in general being diagnosed with cancer. Next one, please. And sometimes they either get diagnosed very late or they get recurrence because, and they know about it later on because they don't have the time for follow-up, etc. So in terms of enrollment in research, we see those kind of barriers. Also, access to academic centers or specialty centers, lack of information. Sometimes they say that Latinos don't want to participate in clinical trials, but it's usually that they don't get invited, because once they are invited, you can see they're very committed and they find through. Next one, please. And facilitators will be really, since the design, all these things have to take into account before the research is even approved and moving forward. There should be partnership with community centers and NGOs to get that to participate. Investigators should have people that work with them that look like the community they're going to serve. Culturally adapted. As Latinos, we don't go to an appointment alone. We go with the abuela and the aunt and the brother and the sister. So it's a cultural thing, and we have to take that into account. Next one, please. And this is talking about minorities participation. A lot of you might know Sheila, and she has, she's also fighting for African American to participate in clinical trials, and she's doing it, and her life expectation has been increased because of her participation and opportunity. Next one, please. So in conclusion is advocates play an important role in every aspect. We have to sit at the table. As advocate, we have to know the people we serve. And even if we are not Latinos, but we're serving Latino population, let's talk to them. Let's bring them to the table. Inclusion of diverse population research and deciding committee is important and guarantees justice and scientific reliability. And it's important for funding agency must require inclusion of diverse population. I think if people can get away with murder saying that, as I say, they didn't get or people didn't want to come, they should make them accountable. They should accommodate for that to happen. And researchers have to thoroughly plan for the recruitment of minorities. Requires detailed plan since the beginning of the idea. Next one, please. And it'll be my last. And this is my favorite picture, to never give up. When I was, the picture in the middle was after my first surgery in 2003. It was December 15, my surgery, and this was New Year's Eve that year. And my boys were 14 and 10 respectively. And now they're, both of them are mechanical engineers, actually living in Orlando. And I'm actually today in Orlando. I came to surprise them, because for the pandemic, I haven't seen them in a long time. So I decided I needed to see them. And they're both mechanical engineers. So it's never give up and to keep serving and helping other advocates. That'll be all. Thank you.
Thank you, Dr. Segarra Vasquez, for empowering us to amplify our advocacy to be the missing voices from the conversation. Finally, we will be joined by two of your peers and longtime Komen supporters, Felicia Johnson and Sheila Pettiford. Both these incredible women are joining us to share their journeys, their narratives, and how they are embracing every day living with MBC. My words cannot even begin to convey their commitment, their passion, or their stories. So ladies, I invite both of you to introduce yourselves and the story of your lives and journeys into your own words. Felicia, let's start with you.
Good evening, and thank you so much for having me. I feel very privileged to be alive today as an MBC patient. As the doctor spoke about the history of metastatic breast disease, I am quite familiar with the cancer continuum because I come from a historical background of 8 women being diagnosed with metastatic breast cancer since 1975. So I have literally walked the path of scientific discovery. I was diagnosed myself with metastatic disease in 2003, and today I believe it's a miracle that I'm alive, and I'm grateful for the continued research and the work that Komen has done in giving dollars to metastatic disease.
Thank you, Felicia. Sheila.
You're mute.
All right. So sorry, everyone. I said such a nice introduction, too. Anyhow, what I was saying is thank you so much for being a part, for the opportunity to be a part of this wonderful conference. The information was astounding. I'm so excited. I really am. My journey with metastatic breast cancer began in 2014. Originally, I was diagnosed with with breast cancer at stage 2, probably 2B in 2004. And I went through the normal mastectomy, chemotherapy. I didn't do radiation because of the mastectomy, and I didn't feel that radiation was the thing for me to do. 10 years, it was quite a surprise, I must say. It was quite a surprise to find out that I was now dealing with a cancer that my doctor didn't tell me, but I looked on Dr. Google and found out that I was now dealing with what was called an incurable cancer. So that was quite, I don't even have words to describe what happened when I saw that information. but I want to say that I have been so encouraged by being associated with the Coleman organization and Felicia. I went to a conference and met Felicia, and just hearing the things that she had to say about her journey has given me a voice. And I have been active in various groups ever since.
Thank you, Sheila.
Mhm.
Let's start by exploring the topic of managing care, and more specifically, self-advocacy and developing your voice. Felicia, Sheila, talk us through learning what information you want to know and how to ask for it, how advocacy is not one size fits all, and why it is essential to find your individual advocacy style, and why more than ever, it is critical to be included as voices in the treatment and care conversation. Felicia, start us off.
What I believe is, as it relates to patient advocacy and having your voice, it gives you power in an environment where the disease has caused you to lose power across many arenas of your life. And so developing your voice is actually determining what information you need to know from your primary care team, what information and support and discussion that you are going to have with your family, especially for someone like myself. I was diagnosed de novo metastatic breast cancer and was in utter shock that I was stage 4. What information is going to be necessary for my employment, my insurance benefits, and just having that control of, let me sit down, discuss what's necessary. After I receive my information from my care team and taking that information back to my family and my caregivers, and being a caregiver also in this arena means that if I lose my voice because of fear, depression, and uncertainty, letting my family know what my needs are so that that primary care person can discuss that with my physicians.
Thank you,
Yes.
Felicia. Sheila.
Yes, absolutely, Felicia. That is so true. The hardest thing for me personally was to, as I said earlier, was to process this information. And I had to deal with that not coming from the oncologist perspective. I had to deal with that on my own. So I realized that right then and there that it was so important for me to make sure, unfortunately, I had to change oncologists. And so when I decided to get a new one, I knew how important it is for me to be able to make sure she understood where I was coming from and not just treat this disease, but to treat me and my personal circumstances. It was very unfortunate. My daughter was pregnant. She was on bed rest. She's a healthcare professional. She's a nurse. And I did not really want to tell her what was going on. So I had to figure out a way to advocate for myself. And the most important thing to do is to kind of sit in it for a moment and to realize that this is a serious diagnosis, but it is something that once you get all the information, you will find that there is hope and there is a lot more to it than what has been talked about, as was shared in this conference this evening. So personal advocacy is extremely important, and the best way to do it is to do whatever it is that you need to do as an individual person, to find an oncologist and develop a team and develop a relationship with that team that's really dealing with you as a unique individual and not a person with a metastatic diagnosis. Then it did lead me on into advocacy for others eventually. And I too was a person who has participated in the lobby day with Coleman. That was a beautiful experience last year. I was so sorry we weren't able to do it in person this year, but I did it virtually. And personal advocacy leading to advocacy for other people gives me an opportunity to just talk to others and make sure they understand this might be considered terminal, but it doesn't mean that you have to stop living.
Thank you, Felicia and Sheila. Next, we'll be discussing embracing every day and living beyond the MBC diagnosis. Although we recognize that it is incredibly difficult to speak about, as one of our panelists profoundly remarked, coming to terms with terminal allowed her to continue to live her life. Although not the story for all of us, our panelists will speak their truth on their own process for living and leaving their legacy. Felicia, you've had a unique perspective as a caregiver for an MBC patient, your sister. Please start us off.
So I was a caregiver for my sister who had struggled with MBC for several years. And when it came to the discussion of her being terminal, I remember the doctor coming in and talking to both of us and saying, we've done the necessary lines of treatment. It is now time for palliative care / hospice, recognizing that palliative care is different than hospice was step number one. So the palliative care was to make her comfortable. And when she transitioned into hospice care, my position as her sister, having the same disease and being 9 months apart in age, was emotionally traumatic for both of us and very difficult because I had to go into the room and explain to her that it is now time for hospice and do it in a very straightforward but gentle way and find the soft words to say to her and respect her emotional space as she dealt with what was transpiring. And as her caregiver, that meant that holding her hand while simultaneously stepping back and allowing her the time to process the information and giving her what I would term as emotional freedom. There is no right way or wrong way to accept the fact that treatment is over. It is now time for hospice, and beginning to process what her legacy is, what she would like to share with family, loved ones, and friends. And that portion of our discussion is really linked to where you're at in your life, what age you are, married, single, divorced, children, grandchildren. So I would say to anyone that's a caregiver that you have to take all these other playing fields into your discussion, because I've been a caregiver to someone in my family that was 32 and had small children. I've been a caregiver to someone that was 60 and was a grandparent. So you need to take all these things into discussion when you're approaching your loved one and have to tell them you're terminal, it's time for hospice. It's very difficult, it's very emotional. I remember when I walked away from the doctor thinking to myself, how could that be? And we both have the same disease. Why is she dying? Why didn't the treatment work for her, but it worked for me? And I needed the necessary skill set. The word I would choose is grace, to deal with her anger, to deal with her disappointment, to deal with her recognizing that she is actually going to die, and respecting her wishes as it related to preparing for her funeral services. And in the metastatic community, these are emotional, painful, difficult discussions to have with your loved one and extended family members, and bringing that information to the family and being her voice and her behalf and respecting her wishes.
And what Felicia is saying, it relates to a person such as myself. I was not a caregiver for someone with metastatic cancer. However, I have met some wonderful people in my 6 years of dealing with this disease that have passed away. So there's something called survivor's remorse, and I've experienced that during some times in my life when people who I've gotten very close to, I could think of a few names right now, and if I mentioned them, you would know them because they were very active in the cancer community, period. And once they got into the metastatic realm, they still were active as far as they could until they were no longer here. It's hard. It's very, very emotional. Just like you said, Felicia, it's very emotional. But what I find that gets me through this and what has been a benefit for me was initially, once I got the diagnosis, I was in my 50s and I was working, and I did have to make the difficult decision to decide not to work anymore. And it helped a lot. It absolutely helped tremendously. I was fortunate enough that my financial situation was such that I could go into that terrible waiting period that the bill is trying to stop happening for people with metastatic breast cancer that Coleman talked, that I believe it was Merle who talked about it. I did have to wait 5 months to get Medicare. I did have for, that was for the Social Security disability. I did have to wait for that. And I also had to wait 2 years to receive Medicare. The good thing is, again, I was in a situation where my treatment was taken care of. But oftentimes that is not the case with people. One thing that I did while I was going through all this was do end of life type things, the things that we all should do, no matter what age you are, but don't want to because it's just not pleasant. Who wants to think about the end of your life and what insurance you need, what funeral services you want to have? You don't want to look at that type of thing, topic, but it was necessary. And one thing I can say, once I did it, I put it aside. Then I didn't have to do it anymore. I then began to think about how important it was for me to live with this disease. And the blessing in all these wonderful things that are happening, the doctors were talking about it, it's so much more energy involved in the metastatic community. We are living with metastatic disease for longer years than ever before. And it is something that we have to now grasp hold of and say it's chronic. Yes, it is very, very serious, and everyone has a different journey. It is chronic, but we have to embrace life. We have to embrace life. I recently just turned 62, and for my 62nd birthday, a friend of mine, we decided that we were going to go to I thought it was going to be all zip lining, but anyway, it was a park that had some zip lining in it, and it also had these bridges, wooden bridges, way high up in the trees that I had to navigate. Did I get scared? Sure did. But I did it. I spent 2.5 hours, well, not really, but I spent some time in this park. And after I finished, I said, wow, I was able to do something that other people maybe not even don't even think about doing, or some people do it with no thought to it whatsoever. But it was a monumental thing for me, just to be able to know that the medicines that they have now developed for metastatic disease are working. What I take specifically is Ibrance and Falcidex. I'm only on my second line of treatment. And at one point, they didn't even have something, but as the doctor said, such as Ibrance. So I am just so excited about life now. Yes, I live with something that could take me out, but I could walk outside the door and get in my car and get hit by a bus or something. So I'm able to manage my life and manage this disease with my faith, with my involvement in various breast cancer, metastatic breast cancer specifically, communities, and just knowing that whatever it is that I do today can help somebody else tomorrow.
Thank you, Sheila and Felicia, for sharing these vulnerable moments with us and handling it with such grace and strength. I'd like to invite each of you to leave your peers with one final thought or remark, something you wish you could say to all of them if we were able to be together in person.
Felicia, if you don't mind, I would like to go first. For me, I've said it 2 or 3 times already. Never give up hope. Hope is something so intangible, but it's the lifeblood. It's the lifeblood of anyone dealing with anything. I mean, life right now with COVID has put us in so much of a different perspective about everything and what it is that we need to hold on to. And however you get it, again, I use my faith. I'm a Christian, but there's all kinds of ways from your family, from your friends, from your work, from whatever it is you need to do. Just stay hopeful. Felicia?
I'd like to echo what my lovely friend said, and just add this additional thought. When it comes to your mental health, get the services that you need. Reach out and talk to your social worker, your oncologist, your nurse practitioner, because this is an environment where depression can be overwhelming as the disease process continues. The depression can also be challenging because the side effects can change your life and the way you process living. But I also say, decide to live. In spite of the disease, decide to live. Whatever living looks like to you, live and make those necessary changes and have the fun you never thought you would have. I've done some things also, as Sheila said. And so I would say, decide to live, take care of your mental health, reach out to get the services that you need in regards to that. Be your own voice, step out of your own boundary and be your voice. And you will find that processing this community will change for you.
Absolutely. I completely concur with Felicia.
Thank
One
you.
thing. Mhm.
Go ahead, Sheila, if you have a final thought.
Yeah, I'm just really piggybacking on her. She said it very eloquently, but I did not, you don't really want to talk about those days when depression overwhelms you, because we're trying to talk about managing, but I might as well be transparent and honest. Depression came. It definitely did in my situation. And it can come with anybody who's dealing, again, with metastatic, of course, but with any type of cancer or any type of chronic illness or something that there's incurable. So the mental health part is extremely important. And I can't say much more than what Felicia said, other than do it. I did see a counselor. Yes, I did. I went to a dark space and needed to have something that would bring me out of it. So I'm a firm advocate for self-care in that way. See a therapist. There are mental health professionals in all different capacities that are available to us. That's a part of palliative care, I consider it. So thanks for saying that, Felicia.
Yes, absolutely. It is so relevant to remind everyone here tonight to not just take care of everyone around them and all the things they have to do, but to take care of themselves, mind, body, and soul. So thank you, Sheila and Felicia, for sharing with us your hope, your resiliency, and your stories that are still being written. I'd now like to begin our Q&A segment. So we will address any questions that are submitted via chat first and then open up the floor. We're going to try to keep our commitment to ending at 7:30, maybe plus or 5 minutes, depending on how many questions we get in, since we know many of you have families and other obligations to tend to this evening. If we do not get to all of our questions, we will work to provide answers to the group via email later this month. So I see quite a few of us have asked to share the advocacy website, and I will be happy to send that around in an email following this program. I'll also include a recording of this evening so that you can share and watch this video whenever you'd like. But since we don't have any questions in the chat, I'd like to invite anyone who has a question to just unmute themselves and ask whoever it is intended for. Well, I will go then, and it is to specifically towards Meryl and Dr. Segarra Vasquez, and someone who is in the space of supporting MBC patients and survivors. How can I be a better ally for MBC patients, and using my voice to talk about policy and legislation and sustaining their quality of life and care?
I can start. I think it was very clear hearing Felicia and Sheila talking about their story and how powerful that was, and how it resonated with all of us tonight. Just imagine when a legislator hears that story, when someone who has that ability to make a difference. So yeah, your stories have power. And even if it's just sharing it with a group tonight, it has power. It has a positive effect. Sharing it with the outside world, sharing it with within public policy, within the newly diagnosed. I think that's the reason why so many of us have become advocates, is that while we're helping ourselves, we are helped by helping others. It's that sharing of energy that I think is so valuable, and that not only helping others, but in doing so, giving us strength.
And as I mentioned, I worry a lot about Hispanics and Latino in the community. And before this talk, I had a chat with a metastatic patient. She's from Puerto Rico, but she lives in Orlando, and she has lived many years here. To understand, because as I mentioned, I got diagnosed, and all my treatment and everything was in Puerto Rico. I had a great insurance, I had great family, but that is not the case with everyone. And I think we have to open our ears, and because our stories was successful, it doesn't mean that everybody else's is. And we have to do whatever we can to have, that contribution. And sometimes we think that nobody will listen to us, but they do. Just sitting at the table at SWUG, I push them to do trials in Spanish, or to think about that community. Or an advocate from a study, and she was saying, well, we might not have this in Spanish. How would a translator work? Translator said, it won't. If you better find someone who speaks Spanish so you can have that engagement. So I think, my encouragement will be, listen, I can just stay happy in Puerto Rico and with my life, and there's no problem. We meet our doctors, we speak the same language. But I know there's more than 4 million Puerto Ricans in the United States. So I worry for them and the rest of them. And Latino community is very complicated in terms that we're very different. Our faith, from Cubans to Puerto Ricans or Mexican, and all this changes. We have a lot of things in common, but there's so it's very difficult to put everybody in one bucket. So we just have to listen, learn about community, and be there, and if I'm not metastatic, but I can, if I sit and listen to wonderful people like Felicia. I had the honor to meet her in Project Lead, so she's my friend.
My friend, yes.
And a lot of people as well. But I think that's what we have to do. Open our ears and advocate wherever we are, at a party, in a meeting, in wherever you have the opportunity to talk and make things better, just do it.
Thank you, Meryl and Barbara. So if there are any other questions, and if you are particularly shy and you would like to ask a question, please do feel free to email me, and I will be sure it gets directed to whomever it is needed to go to. So I do want to conclude this evening by saying that it has been both an honor and a privilege to share this evening with you, to have this platform to design and present this program. Tonight, we have translated awareness into action, focused not just on today, but tomorrow. I wish you all a peaceful evening, and as always, I look forward to seeing you next time. Good night.
Good night, everyone.
Good night.
Good night. Thank you.
Our stars, our warriors.
Thank you, Elaine.
Hi, Jamil.
Hi.
Hey, Jamil.
Bye.